Good afternoon, everybody. I'm happy to be here, and the name of my talk is Improving the Health of Individuals and Populations with Electronic Health Record Data. Before I get into that, I wanted to more broadly mention data science skills that I think we're all very familiar with. Most of us would say that programming and statistics and machine learning are sort of foundational skills that those of us who do data science, regardless of where we're doing it, have in common. Additionally, there is domain expertise, and I would like to emphasize that this is something that should not be underestimated, because how you apply your programming and statistics and machine learning skills will critically depend on what domain expertise you have. And therefore, I will start by discussing a little bit about the domain in which I work, and if you ever would like to be a data scientist using healthcare data, I would encourage you to get experience in that. So let's discuss electronic health records. As the name implies, these are digital records of patients' health information that are gathered via encounters with health providers. Occasionally, they can be gathered directly from the patient, but usually they're gathered for administrative or clinical purposes when you're encountering a health system or anybody who is a patient. These were rapidly adopted across the United States after the Health Information and Technology for Economic and Clinical Health, or HITECH Act of 2009. And I mentioned that because notice that this is 2009. So electronic health records, their adoption across the U.S. has actually been relatively recent. We don't have historical electronic health record data for most health systems across the United States. There are a few electronic health record vendors who have grown and dominated the market since this act. And I also mention that because it may have been the case decades ago that you could just create a database and that would be an electronic health record. But now there is a lot of bureaucracy, legal, administrative issues associated with having an electronic health record system. And there are standards for interoperability that have increased the ability to exchange information across health systems. But usually when people discuss doing research or using electronic health records, they're talking about data within one health system. There are ways to share data, but one has to be very careful about this because, of course, as a patient, you don't go and visit a health provider for them to share your data across other systems. So there are other reasons why health record data analysis is usually done within one geographic area and more specifically a health system. Electronic health records are valuable for research. So even though their primary purpose is not to do research, it's to, again, fulfill missions of health systems, administrative and clinical care functions, they can be very valuable for research. They provide convenient and low-cost access to longitudinal information for many people. They can be used to contact people for research studies. So maybe you're not using most of the data in their health record, but you're still have permission to call people and say, would you like to enroll in a clinical trial or some other study to better understand a health condition? They enable the improvement of clinical workflows at the point of care. And so maybe within the health system, you notice that there is some slowdown or something that can be done as you're providing care for people to speed up or improve services. They've been essential for the creation of biobanks, and most biobanks contain genetic information for people. And for genetic studies, you actually need very many patients or very many subjects. So a lot of large health systems have started to collect DNA, or actually they have done this for the past decade or so. And so they have very large repositories with which you can do genetic studies. And finally, their data can be used for primary research, and that is to just understand health patterns that people have, and that's what I'm going to discuss. But that being said, important health-related information is missing from electronic health records, and especially if you compare them to, let's say, conducting an epidemiologic study where you would very purposefully collect a lot of information for people. If electronic health records are being used for administrative or clinical care, then obviously how people visit health systems or how data is gathered once people are in health systems is going to be very biased. So among the things that are missing are socioeconomic status, education and health literacy, and environmental exposures. And without telling you anything further, I think you can recognize that all of these are very important in many health outcomes. One effort recently is to try to expand the scope of electronic health record data, and one way to do that is by linking it to spatially varying information. And what do I mean by that? Let's say you have electronic health records for people. There can be geographic identifiers within that, including people's address, and let's say for children, their school, for adults, their place of work, you can try to link these geographic locations to other things that happen at those locations or to other exposures that may be present at those locations. And that is what is depicted in this figure. And this is possible because there are many publicly available data sets that capture social, economic, and environmental conditions. And once you have these external variables, you can treat them as covariates and regression models to try to find associations or patterns related to health outcomes, not just regression models. Maybe you want to try machine learning models. And you can also perform spatial analyses to identify hotspots or regions, geographic regions that, let's say, are more at risk, or people that are in these geographic regions are more at risk for certain conditions. I'll give you some examples about asthma, so let me tell you a little bit about asthma. It's a chronic inflammatory lung disease that is characterized by episodes of airway obstruction, and usually these episodes are related to environmental exposures, maybe viruses or pollution. People with asthma usually have constricted airways, as depicted in this figure in the middle, but when you have a worsening episode termed an exacerbation, your symptoms get so bad and you have so much trouble breathing that you usually need to take drugs to sort of overcome that, usually oral steroids. Asthma does not have a cure, but treatment according to clinical guidelines can decrease symptoms, exacerbations, and improve lung function in most patients. However, there are marked disparities by race, ethnicity, and asthma prevalence and severity that are well known in the US. So let's go back to electronic health records and consider Penn Medicine asthma patients. And Penn Medicine is a large healthcare system that serves the greater Philadelphia area. Those of you who live around here probably know this. According to electronic health records of over 9,000 asthma patients that we being the health system, encountered between 2011 and 2014, we can note that they are 75% were female and over 50% were Black. And I know this figure on the right sort of, I'm only showing bars for white and Black patients. Of course, Penn Medicine sees patients of many other racial ethnic groups, but these two account for over 90% of the patients that we were observing. So I'm just showing two bar plots. So how can we interpret these bar plots? And for doing that, in most studies, you would have some kind of control group. Maybe you can compare this to the general population and say, well, this seems like the general population is split evenly by male, female, and certainly 50% of people broadly in the US are not Black. So how do we compare this to some other group of patients to know what this means? And that is an inherent limitation of electronic health records, is that it's usually not clear to say what your control group is. One thing that we could do, though, is let's say look at all asthma patients, or I'm sorry, all patients that were observed or that were encountered at Penn Medicine during the same time period. And that gives us about 3.2 million patients. And all of the patients during this time, 60% were female and about 30% were Black. So even without doing any statistics, you can see that there is some kind of disparity happening by sex and by race, and this disparity that we're observing is consistent with what we would see nationally. So to further study asthma patients, because we don't have a good control group, what we can do is look within asthma patients and say who's more at risk for having exacerbations, which are, again, these episodes where people have worse symptoms, and they are a greater burden on the health system because people have to come and visit the hospital system, potentially be hospitalized, although that is not necessarily happening all the time. Exacerbations, we are going to define them as a prescription for oral steroid during a primary asthma encounter. So again, people are visiting an outpatient provider, the emergency room, or they're being hospitalized and oral steroids are given. If we look at that and consider like a 3-year time period for any given patient, there's some patients who have no exacerbations, some may have 1 to 2, fewer have 3 to 4, and even fewer have 5 or more. But if you think about it, these sort of groups that have 3 to 4, 5 or more exacerbations are just sort of having an extremely high burden of disease compared to everyone else, right? Like there's potentially, we'd like to avoid people having this many exacerbations, as obviously the patients themselves would like to avoid having as well. So let's just look at these very broad characteristics of patients, and we see that about 75% of the patients, no matter which exacerbation group we're looking at, are female. But if we look at race, we start under no exacerbations. There's about 50% of the patients are Black. And for simplicity, I'm just showing one group here, one racial ethnic group. And as we go up, though, you can start to see that by the time we reach the 5 or more exacerbations, 90% of the patients are Black. So we're talking about a small number of patients overall compared to all of them. But this is a very striking disparity. And we can keep using electronic health record data to try to see like what other factors that are collected by electronic health records are related to asthma exacerbations. Not surprisingly, we see things like chronic bronchitis or other pulmonary diseases putting people at risk. But there is some limitation here of like how can we drill down further to try to potentially understand some of these disparities that we're observing. So let's try something else. Let's look at the spatial distribution of asthma exacerbations. And for that, we're going to use residential address to map the exacerbation rates. The approach that we're going to use to measure this is to use a generalized additive model. And this model looks a lot like a logistic regression in the beginning. There are terms for all of the variables that are collected by the electronic health record that we can use. But additionally, there is a spatial term that considers latitude, longitude, sort of divisions of along a grid. And this is one of the earliest maps that we obtained looking at asthma exacerbation rates. And what we can observe is that there is global spatial heterogeneity present. To obtain significance here, there is a permutation procedure that takes place that tries to account for the fact that we don't have an even distribution of patients across the geographic region. But there is global spatial heterogeneity present, and there are significant hotspots and cold spots, and those are indicated by these contour lines. And so I'll just note that there is a hotspot in West Philadelphia where there seems to be a higher burden of asthma exacerbations. But what can we do with that information? And so first, let's note that Philadelphia is a city with diverse neighborhoods and environmental features, as are most places, not just cities, but a lot of places are very different if you go spatially across them, right? And so I will not even enumerate the various ways that our neighborhoods are different across the greater Philadelphia area, but there are many. And so this is one of those motivating factors of how can we take that into account. And further, we know that many factors influence asthma exacerbations. And those factors include area deprivation, which is a marker of socioeconomic status. Here's a map of area deprivation that we had created using a composite score of 12 socioeconomic status variables. This is at the level of US Census block groups, and we used American Community Survey to obtain this measure. We can look at traffic density. Some traffic-related air pollution and other air pollution has been related to asthma. And so here we're expressing traffic density as the annual average daily traffic for all major road segments in Philadelphia. And this is from a data set obtained from the Pennsylvania Department of Transportation. And we can also look at crime rate being a surrogate for potential stress, because people who live in areas of increased crime may have higher stress levels than people who don't live in these areas. And this data comes from the Philadelphia Police Department. And so now let's go back to this model of asthma exacerbations geographically. Our outcome still being asthma exacerbations. As covariates, we're still using whatever information, demographic information we can obtain from the electronic health record. But we're going to compare that to a model where we additionally include neighborhood deprivation, crime, and vehicular traffic. So our first model, and I should mention here that now I am being restricted to the city of Philadelphia as opposed to sort of looking at the greater area. We still see that hot spot in West Philadelphia, though here now it extends a little bit into South Philadelphia. We still observe that there is spatial heterogeneity present, hence that contoured area. But when we include the additional factors, we see that the spatial heterogeneity is no longer significant. And we've looked further at this, and the factor that is most related or most responsible for the hotspot sort of going away when we've integrated the data is area deprivation. And so that suggests that what we're looking at as a geographic effect is related to some kind of indicator of socioeconomic status. And maybe that's not enough information to really understand asthma exacerbations, but it gives us more clues about how to explore that further to potentially decrease asthma exacerbations in our own patients. So more broadly, many useful publicly available data sources exist. I've mentioned some of the ones in the example that I just had. Some are related to socioeconomic status. You can look about more things about the built environment. There's more environmental data available through the US EPA or increasingly through satellite data. An area deprivation index is actually a validated measure that is quite popular now and is similar to the factor that we had created as deprivation. The data quality of all of these data sets will vary in terms of the source, the resolution, the missingness, but I wouldn't say that any of the data sets are just either really good or really bad. It all depends on what question you're trying to address, and the data set may or may not be appropriate for you, depending on what kind of resolution and what kind of question you're being you're asking on your own. And so just keep that in mind, that you can sort of look through all of these publicly available resources and then try to figure out, is there any of them that would really help me address a particular question that I have. And so we've tried to integrate more of these data sets for the Philadelphia region, and that is partly because I work at the Center of Excellence in Environmental Toxicology, and one of our goals is to relate environmental and social variables to all kinds of different health outcomes, not just asthma, as I mentioned as an example. We additionally have low-cost sensor measures for air pollution. Mostly when you take these measures, you also get temperature and humidity. We have EPA air pollution measures, and these are taken at regulatory monitors, so they're of the highest quality, or they're considered the gold standard. We also have area deprivation index, crime, traffic, tree cover, and we focused on the Philadelphia, Reading, Camden combined statistical area, which is in the outline and the map there on the right. And again, that is partly because for our own local health studies, this is the region that we're interested in. And some of the data sets that we're considering do not span, let's say, the whole country. They span this particular geographic area. And we've combined this data into an app called Sensor-Based Analysis of Pollution in the Philadelphia region with information on neighborhoods and the environment. It's an R-Shiny web app. And the idea here is that people can go and just visualize some of these data sets and how they're distributed across our region. This may help with generating hypotheses, or just download data to do further studies there. It's also available as an R package that is more helpful if you're actually doing a health study and you need to relate a lot of these variables. So it saves some of the time that people may have when they're sort of repeating that process of downloading, creating a raster, and other quality control that you need to do before you use these data sets for a study. So with that, I'll mention my conclusions, which are that electronic health record data can be augmented with publicly available data related to social and environmental characteristics to better understand individual health risk factors. And geospatial analyses based on electronic health record data can identify regions at peak risk for disease to motivate public health interventions. And finally, I'd like to acknowledge the many people who helped make this work possible. Hi.
Hello?
Hi, Linda. I can hear you.
Good to see you here, and thank you for a wonderful talk. I actually have a question about your EHR data. So this asthma data, is that, because that's available from Penn, right? Without that data to start with, there's nothing else we can really, I mean, your work is built on that, but that's not publicly available, right?
Oh, no. No. Absolutely not.
I mean, so this is what I sort of puzzled, that EHR, of course, that we all know it's already collected, that all the researchers can really are ready to make a move to dig out, scientific problem or even any type of problems we can solve. But we can't get hold on those data.
Well, people can get a hold of electronic health record data, but you're absolutely right that no health system is just going to put their data completely out in the public domain. I suppose there are instances where there are de-identified data sets that are made publicly available, and any of you who want to know specifics, there are some very famous data sets that have been publicly released, but that's under very specific circumstances. However, at the medical school here and other medical schools and other insurance companies across the country, research is absolutely part of what people want to do. So the catch is that what you have to do if you would like to do this kind of research is that you have to have an approved protocol. So the IRB of whatever institution will grant approval if you have a legitimate question, and you have to explain how you're going to protect the data. Everybody has to be certified that they're, ethics certification, in addition to just, sort of having the right credentials. So as long as all of that is there, then you are allowed to see portions of data. And yeah, separately from that, there are people who do research within the health system, and that's sort of what we would consider operations research, and their whole mission is to make sort of the healthcare system more efficiently internally. That's a little bit different from what I do, because I'm not in there taking care of patients directly. I'm just trying to get data extraction for specific conditions to sort of under approved studies look at patterns.
Well, so thank you. I actually even in the past, I have tried to get data like that through Penn system. It really takes forever to do that. I won't deny that. Yes, I hope that. Do you see any sort of potential that, at least for the purpose of research, that EHR data can be accessible, at least for researchers, in a much simpler way? Do you see that possibility?
Yeah, I mean, I think that it really, again, it comes down to each health system, because I think some health systems they just have sort of different processes. Their data has already been set up. Penn, let's say, is newer to electronic health records compared to other health systems. So there's sort of maybe a slowdown there. But yeah, depending on what health system you're in, different things have happened. So in some, what they did is they did a completely de-identified copy of all records, and that's stored separately from the medical data. And so that's not considered human subjects research anymore. And so anybody can access those databases. That is part of the institution. So we here at Penn don't have that. So we have, sadly, the slower process. But yeah, every institution has to do what they're comfortable with security-wise for their data. And so if you do have the proper IT set up, then it is actually, absolutely possible to have sort of wider spread use of electronic health records.
So thank you, and also that thank you for sharing with us your wonderful analysis that you pointed out that combining with other public available data. It's amazing to see you have a different results in terms of analysis. So very interesting that earlier we have another talk by Ren, an executive and the director in data science. He actually talked from another angle, just saying data analysis, more importantly, is about really the domain knowledge, how much you really know about what you are doing. And now on your side, that you seem to emphasize skills, data analytics skills. Do you want to say a little bit, or maybe because you're already an expert?
Oh, no, I think the domain knowledge is absolutely, no, I would emphasize, I completely agree with that. And this, I mean, obviously the others are important. You can't be a data scientist if you don't know how to actually analyze data. But yeah, for those of you who are trainees, in grad school, I just had some terrible experiences working with people who are not familiar with data. Because if you might pose a question and then answer it in a very trivial way, if you don't understand how, let's say, how an outcome is defined, and then you use predictor variables that are part of the definition, you might sort of get a trivial predictive ability, right? Because you're using, let's say, terms or sort of some of your supposed independent variables are just completely related to your outcome in a trivial way. And so you put them into a predictive model and you're like, my prediction is amazing, but you haven't learned anything. You're just sort of predicting the obvious. And it's hard to say that you could ever figure that out if you don't know something about the data that you're analyzing and what are the goals, right? And that same is like posing the question in the first place. What is it that you want to predict? Like what, let's say in the clinical domain, what's clinically meaningful? If you're trying to maximize profits, then, you have to make a very specific question about that, and sort of know what you're going to tolerate to to learn what variables you're willing to not use, to use, all of that stuff. It really helps to have some domain knowledge. So that's why I would encourage it. It doesn't mean you can't move to a different domain, but just be aware of the fact that you can't just assume that you're going to get a matrix and any analysis, plug that through machine learning algorithms and AI, and ta-da, you're going to get an amazing model. Like, you absolutely need to balance that with domain skills.
So I think I have one last question regarding about EHR data. How much effort has been put into privacy and fairness? Because it's getting more and more, concern, and are the data really already have a layer of privacy protection?
Absolutely, yeah, and that's by law. So even if you yeah, I mean, I think every health system, that's partly why they're so conservative with sharing data, right? Because of privacy. Like, nobody wants to violate privacy of patients. And so, yeah, all of us, when we see providers here in the US, we have to sign our HIPAA waivers. And so there are laws that regulate how to maintain privacy and under what circumstances data can and can't be shared. So there is a lot of concern about that. And then separately, hospitals are a great target for hacking. The hospital systems separately have to spend a lot of their funds on actually trying to ensure patient confidentiality. And in recent years, sorry, that's a little tangential, but there have been instances, right, where there are hacking incidents where the data of patient records is held hostage, and then providers can't care for patients for a little bit because they've lost access to, let's say, the schedules for chemotherapy, the latest doses, and so on. So yes, absolutely privacy. And on the fairness end, absolutely. We're sort of in a very fairness aware, disparities aware time. And so yeah, you can. In medicine, there's a lot of issues right now surrounding, let's say, race, ethnicity, right? So there's certain equations that historically have just been like, patients differ in their lung function and certain kidney values and, all kinds of clinical metrics that maybe weren't based on like complete science. And so if you just randomly plug in some algorithm to predict things, you may trivially predict things related to race that are not biologic, that are not a true biological difference, but just reflect other disparities in society.
Well, so Blanca, thank you so much for being here with us today, and thank you everybody for joining us with this in this wonderful session.